Okay, welcome everyone. It sounds like if you were just at the exhibit hall, I'm sure you're back to back, just like I was. That's where I was hanging out, learning about all this wonderful new products and innovation that is available right now. So we're gonna give everyone maybe about like another 15 seconds before we get started because we have 8 incredible presentations that we want to make sure to get through. If you have any questions, please feel free to raise your hand. This is more of a intimate, ideally more conversation focused discussion rather than what we've had earlier today as part of the conference. And so please feel free to raise your hand. You can also include the questions in the chat. And then what we're going to do is each presenter will have about 2 minutes to walk through their poster. And then we will give, 1 or 2 questions per poster before we move on to the next one. So it'll be a little bit of like, research style speed dating. So, sounds good? Awesome. Okay, Dr. El-Kour, please take it away.
To be here to speak with you today about an interesting research that I have been doing or leading. And my research has actually been focused on the impact of mental well-being and technology adoption on digital behavior response in millennials and Generation Z. And it was part of a randomized control trial where we actually devised a particular model on digital behavior response. But to that end, we more or less looked at does really mental well-being and technology adoption propensity influence the way the millennials and Gen Z really interact digitally with different messages. And as a result, the study was a global study, and it involved around 142 participants who were basically recruited based on a particular criteria that they should fall within a particular age, and they should also learn English and spend a number of hours on their phone every day. And the participants were basically randomized to 2 different groups. The first group was basically exposed to neutral messages or correct or incorrect messages that were simply within non-AR context. And then the other one was basically through AR or augmented reality contexts. And augmented reality, basically, it included more augmentation in terms of a message in relation to an energy mix or a heartbeat mix that relates specifically to heart health, and a corrected messages that relates more to detox. So those were kind of topics that were mainstream, trendy when we did the research on particular health and nutrition topics that govern millennials and Gen Z. And so as we looked at the different messages, the key sorry, I was muted, that yes, there were differences. And what we noted is that, when we subject or we looked at measuring the digital behavior response across the participants at T1, or basically once the study has been initiated, and then after 28 days, which is kind of an approximate measure of behavior change within 28 days up to 56 days. And we noted that if participants are subjected to neutral message, the result was significant at T2, or which is after 28 days versus at the beginning or at the start of the experiment. And it was also significant for correct messages, but it was insignificant for corrected message, or for a message that was corrected through augmented reality while being incorrect in a non-digital or in a digital platform, but with not using augmented reality. So and throughout the T1 and T2, of course, with the well-being index and technology adoption index were measured. So with that, the well-being and technology adoption were basically influenced by time, so minimum 28 days, and also by the message type, as we've noted, the neutral and the correct message, which reaffirms what we already know in literature. However, contrary to what we know is that both factors, basically the well-being and technology adoption, did not really affect behavior at T1, or basically at the inception of the study, and also did not affect it in corrected messages. So despite having high concerns that, incorrect or basically misinformed messages in digital media might influence the digital behavior response of millennials and Gen Z.
Great.
So we need further research to explain versus the variability around that. And over to you, Soo Young.
All right, thank you. We have questions from maybe one or two from the audience. Please don't be shy. You can raise your hand, unmute directly, put it in the chat. Also, I've been told that I will, put people on the spot, so please let's not do that. Yes, thank you, Rachel.
I just have a basic question. Can you just maybe give examples of the different types of messages, or just help us understand, maybe with just some examples of, what you were really comparing in this study?
Yes. So what we looked at basically is, for example, an energy mix is when you look at those energy drinks, for example. So if it is, we provide the message that this energy mix is going to be good for your mental well-being. It's going to improve your cognition. It's going to improve your concentration. It's going to improve your overall well-being. So if you look at the standard image-based context or message versus one that is augmented, that provides the evidence on the cognition, that maybe play a video around what do we know around the detoxing, or around the around improving cognition from recent clinical trials in those particular populations, and in of course in a simple language. And I'm happy to share some of the videos with you if you get in touch with me.
Sounds great. Thank you so much. Okay, we're going to move on to our next presenter, Dr. Daniela Fernández.
Mute. So continue to share. Yeah, okay. So, well, thank you for being in this kind of like virtual poster session. So today I will present some preliminary results from a intervention that was conducted with the purpose of increase white bystander confrontation of online race discrimination. So we were interested in knowing what kind of factor really help people to confront, and what kind of factor really are barriers to confront online racism. So as you might be aware, there is a lot of benefits around social media and online digital tools, but there also is a place where they have been reported racist posts online, and algorithms sometimes doesn't work in terms of that, create more engagement to these kind of posts. So Black people have reported that these racist posts are actually cause a lot of negative impact in their well-being and emotional and so on. So even though confrontation is an important aspect in this situation, confrontation is quite uncommon, and is often perceived as something negative or difficult to do by the non-target bystanders, in this case, white student. So given these barriers, there was an intervention that was created for the team, from part of the research team that's working the Tithe initiative, when there is an online intervention, when one group was assigned to a confrontation intervention that promotes engagement and confrontation to racism online among students from a predominantly white institution and white student. And the rest of the people were to an implicit bias control condition when some implicit bias material was shared. After that, they were exposed to a racist post, and then were asked whether they wanted to confront the racist post or not. And after, they could write a response, and then were asked whether they wanted to submit the response. So the idea was this post was part of a newsletter outlet for a student. It was a very blatant racist post. So what we did in this study in particular was analyze the reason that a student and participant provide to explain why they wanted to, or why they choose to confront or not. So after, all these questions, they were asked why they made this decision. So we create different codes reading the responses. There was like open and the responses from participant. So we asked them, we analyze and make like a coding process to understand what were the reasons. And also we compare the distribution of the reasons between the intervention and implicit bias control. And that way we were interested in knowing what kind of things maybe the intervention didn't address, what kind of things maybe were important to highlight or to prioritize more. So the results were response from 720 participants. And in terms of what was or why did a student in the intervention versus implicit bias control condition confront the pause, the main reason and what we can see that a different reason was the certainty about how to confront. So part of the intervention was tell a student a sort of like key aspect of us how confrontation should be, because there is also a lot of misunderstanding about what confrontation should be. There is the idea that it's like getting in a fight and in an argument. So in the intervention, they were given like certain key aspect to include, just label the pause and just say that they disagree. People in the confrontation intervention group, they felt that they confront the pause because they were feeling more sure about what they were saying. They have the ability, this kind of self-efficacy aspect. And in terms of why students didn't confront the racist pause, we see that the key or the main reason that they provided were the belief that the confrontation is not effective, that it's not going to change the other person's mind, so what bother, that the pause was not a threat or urgent. So they recognized that the pause was racist, but it was not really urgent to reply to them. Mistrust of online platform, like how my data is going to be handled, and they need more information about the outlet of the study, like who is going to post or what is going to be done with my comment, etc. So in part of the discussion, these are preliminary results, and we hope to publish this research during this year, is the importance of individual self-efficacy as a facilitator confrontation, as well as the outcome expectancy, whether the confrontation is effective or not. And also the importance that this reason why not confront were not really reason addressed by the intervention. So we have two ideas here, which one could be that maybe there are things that need to be acknowledged, but there is also plausible that participants did not want to confront and experience some cognitive dissonance, which prompted to give reasons that were not really part of the intervention because they were asked at the end. So some of the response were really like, oh, you caught me, like I should, say something and I didn't, or I should confront and I didn't. So there's these two ideas that show the multifaceted and the complexity that actually confrontation is, but at least we have some highlights of things that can promote this for white students.
Okay, thank you. Okay, thank you so much. Any questions for Dr. Fernández from the audience? Dr. Fernández was very, very clear. I'm sure that has resonated with a lot of audience members. We do have quite a time for one or maybe two, depending on how quickly the questions get answered. So if anyone has any follow-ups, clarification requests, thoughts that were provoked in your brains. Okay, this is unusual. Okay, we'll move on. But if you do have any questions, also please feel free to throw them in the chat. Next, we have Madeline Blackwell.
Okay, I'm Maddie Blackwell, and I'm a master's student at UT Tyler. We did a intervention, we developed an intervention about loneliness and how to target loneliness among undergrad students, which are a vulnerable population for loneliness. The negative impacts of loneliness are pretty well established. Some researchers even compare the impacts to as severe as those caused by chronic smoking or cardiovascular disease. They can have health impacts, mental health impacts, and many negative impacts. So we developed an intervention that was based on ACT-based principles, so self-compassion, self-awareness, things like that. And we wanted to address how to basically increase engagement in interventions. So we conducted interviews. Participants completed the intervention and they completed some survey questions as well. And then we completed interviews with them. So we did semi-structured interviews with a small sample of 6 participants. We were anticipating more, but data collection is ongoing, and so we're still hoping to get more. But we wanted to get in-depth and rich data from these participants. So we completed these interviews with them. We analyzed the transcripts using reflexive thematic analysis from Braun and Clark. And so we went over these transcripts together and developed codes, and we developed comprehensive themes to recognize the content of this intervention and the feedback that we got from these participants. So some of the main themes that we found were personalization. So participants wanted to be able to kind of customize and personalize their engagement with the intervention. They also wanted to be able to interact with it. So rather than just static, just watching a video or just doing something that didn't require interaction, they wanted to be able to interact and to give input as well as receive information. They did care about the design, so it wanted to be appealing and in a way that they were interested in the presentation of it. And the type of communication was also very impactful. So participants were particularly interested in a mixture of statistics. So they were interested in things like stats like 50% of college students experience loneliness at one time or another. They were very responsive to that type of data. They also were appreciative of emotional content, so content that helped them connect with their own personal experiences of loneliness and recognize like the universality of it. They also valued content that helped them to create an action plan. So they wanted to be able to have specific ideas of how are we going to make this happen? How are we going to reach out to people? How are we going to recognize people that are lonely and to be able to reach out to them? They also kind of had like a shift of recognizing that everybody else also experiences loneliness too. So those are some of the themes that we found. Overall, the interaction was one of the strongest themes that I noticed. They were very invested in wanting to be able to interact with the content in order to be more engaged with it. These participants had all recently experienced loneliness, so they represented that population. But we did have some limitations, as I mentioned, even though with qualitative research, we want a small sample so that we can get rich data. We did have only 6 participants when we were aiming for at least 10. So as I said, data collection is ongoing, and we are continuing to refine this intervention for future research. Any questions?
Thank you. Given the emphasis that everyone has been talking about already as part of the different sessions that we've had in the importance of getting users engaged as part of the development process, this seems super relevant. So any questions for Maddie from everyone in the session? Yes.
Hi, I'm Tina. Thank you so much for your presentation. And I was also thinking of Dr. Fernandez's presentation with this question too. I've really been mulling over how do we think about engagement and what's the border between engagement and being addicted to these different types of digital interventions. And so I find myself just going back and forth and having absolutely no answers on, is something engaging, it's really helpful, it's promoting things like self-efficacy, it's decreasing loneliness, it's doing all these fabulous things. And then we also want it to be engaging, but not so engaging that that is the only thing that's available, and that we're also kind of helping young folks and people who are in distress to also build internal resources and resilience. And that first part of the question was all of my own anxieties about where we're going with the digital world, but maybe from your professional opinion, what you know in the literature, how are we handling the border between engagement to promote self-efficacy learning, internal skills, and then where are we stopping so that something doesn't get addictive for folks?
Yeah, that's a really important point for sure. I think it definitely depends on the type of intervention. With this one, it was kind of the content, it was like videos and then text responses. So with interventions of this particular type, we haven't run into any problems that I know of so far with getting so much engagement that it becomes addictive. We tend to err more on the side of getting enough interaction and enough engagement for people to really see results with it. So for this type of intervention specifically, I would say we haven't necessarily gotten yet to the point where we would be in danger of addiction, but that's definitely an important point to consider, especially depending on the type of online intervention that we're using, since technology can have different impacts than like in-person interventions for sure. Does that answer your question?
Yeah, thanks.
Well, thank you so much, Emma. I'm so sorry. I see your hand. If it's okay to start the conversation in the chat, I want to make sure that we're also giving the other poster presenters a time. So Stephen, you're up next.
All right. All set? Great, you hear me?
Yes, we can.
Okay, great. Hi, I'm Stephen Fleiter. I am the co-founder of Online Interventions. Despite decades of progress in addiction treatment, a major gap still remains. Last year, over 50 million Americans needed help for a substance use disorder, yet only 23% received care. Even more concerning, of the people who did not get help, fewer than 4% believe they actually needed it. However, there is hope. A 2020 CDC study found that 75% of people who engage in treatment, evidence-based treatment, do recover. So the issue isn't whether treatment actually works, it's helping people accept and engage with it in the first place. That's where interventions come in. When done properly, interventions led by family and friends, we have found have an 80 to 90% success rate in getting a loved one into treatment. But here's the major challenge. A professional intervention in the United States can cost anywhere between $5,000 and $10,000, and they're not covered by insurance. This is making them inaccessible for most American families. At Online Interventions, we have been working to change that. We've built a platform that it combines custom-built software with one-on-one support from trained intervention professionals to guide families and friends, concerned loved ones through every step of executing a successful intervention. We work with digital health providers and treatment centers and community organizations to make this resource accessible to anyone that needs it most. And if you work with people who are impacted by addiction, we'd love to connect with you and learn more. Our current research has found that we have an 83% success rate of those who do go through the tech-enabled care delivery. And we're also working on the huge problem of clinician burnout and providers that either they're not professionally trained or they're burnt out with their workload. So we've been able to save clinician hours with the tech-enabled care delivery. In addition, reducing the cost of the extraordinary $10,000 to $15,000 upward intervention costs, which is only serving the 1% in the country for this vital service. But the primary goal of getting people to engage in that first vital step of care is what we're looking to solve, and have proven that with technology, we can get more people to take that step into digital solutions and other treatments. So, any questions?
Danielle.
Hi, Stephen. This is really interesting. I have two questions.
Yeah.
One is how much is the online interventions, and two is how are you measuring, like what are your metrics for success?
Great question. So the pricing is flexible all the way down to $0, depending on who the payer is. Right now we're experimenting with different price points depending on if it's the consumer, working with strategic partners. But we can lower the cost to make this a free resource, which we believe as intervention is the first step on the patient journey. Just like an emergency responder, this should be covered and free to all that need it as a vital entry into mental health care. So pricing is quite flexible in testing. We believe that insurance companies and providers that do have budget would be the primary payer, and then give that resource to those who need it for free. but we're on a mission to make this accessible for anybody and making it a free resource. So, and then how do we define success? So we've gotten this question all the time: is success getting someone to engage in getting into a treatment program? Is success having a difficult conversation where you resolve a conflict, even if it doesn't go into the preferred outcome? So we are tracking different things. The primary metric we're tracking is, do we have someone engaged and step into a type of clinical care protocol, whether that be an assessment, outpatient care, treatment. We're just testing to see if through a conversation, will someone take a step to initiate primary care?
Thank you.
Yeah.
Okay. Thank you, Danielle, for your question. Next we have Arathi. And either the chat is living up. So if you have any questions to throw in there, please throw it in so we can continue the conversation as well.
Hi, everyone. I'm very thrilled to be presenting our narrative review today on Arabic mental health apps. So I'll be throwing out some numbers. There are over 400 million Arabic speakers in the world, including me. Just to put into perspective, that's basically more than the population of the US. And when you look into the app stores, you would find around 10,000 mental health applications, but only around 100 support the Arabic language, which means that's like basically 1%. That's very tiny because there's a huge need right now for mental health applications for Arab users, especially with everything going on. So just the aim of this review is to look into kind of get a general understanding of the current status of Arabic mental health by analyzing the therapeutic and engagement features. And when we talk about therapeutic features, we're just looking into evidence-based functionalities and going kind of back to the scientific foundation. So what you can see in Arabic mental health applications are psychoeducation and sharing capabilities. But a lot of the apps are missing evidence-based interventions, visual aids, healthcare professional support, which is very, very important, and customization and personalization, which everyone has been talking about tonight. When we talk about engagement features, we're looking into kind of how can the user maintain and come back to the app whenever they need to and stay and sustain therapeutic involvement. So what we saw is that a lot of the apps actually had offline mood and reminders, but they also lacked gamification and social support. A big absence was mobile sensor integrations for mental health promotion. And I do believe therapeutic features go hand in hand with engagement features to ensure the optimal user or the patient outcome. Christina brought up an interesting question about engagement, drawing the line between engagement and addiction, but we can go back to that later. Also, we're missing out onto kind of real-world evidence. There isn't much randomized controlled trials that are going on. And one of them that actually was done is for an app called Sanadik, in Arabic means your support, and they found out interesting results in kind of a huge reduction in post-traumatic stress symptoms, as well as a decrease in self-stigma. And I think we do need more of those trials to be able to kind of evaluate mental health applications and guide future developments. When it comes to future recommendations, it's basically everything that has been said today, and I think we need to kind of collaborate with diverse teams and kind of get on board with other users, as well as kind of develop kind of very sensitive to culture and language individuals, as well as kind of unify communication channels across different institutions and sectors. As we also mentioned tonight, kind of the involvement of AI is very important because it's part of our everyday life, and it's been kind of playing a role into our mental health. So involving it into those applications is kind of key. And we're currently building kind of an application that is specifically targeted for Arab populations and especially kind of unique to our different culture and healthcare needs. Thank you. I'd happy to answer any questions.
Thank you so much. Any questions from the audience? I did not know that there were only 10 apps that supported the Arabic language. That's
Actually 100. Sorry, I
oh,
might have
100. I'm sorry.
100.
I totally misheard you probably. In my head, that's equals to 10. It's like very
Yes.
little to nothing. Okay.
Exactly. It's just 1% compared to the overall application. So
Okay. Why don't we go to the next presenter? But again, if anyone has any questions, please add them to the chat. Next, we have Nikita.
Yes, hello. Let me just share my screen. Okay, so I'm the design and methods I wanted to talk about today were for a study that is called Move with Meaning. And we know there are text-based programs to help adults with increasing their physical activity in midlife, which is sort of a big critical time in the prevention of cardiovascular diseases and other metabolic disorders. But something we kind of integrated in this study was sort of a podcast kind of format. So every week, participants would listen to around a 20-minute audio session where a few of our psychiatrists and clinical psychologists would guide them through a program that's looking at helping them set goals with physical activity, cover different strategies like things like SMART goals and how to set them. And then along with that, each week they get text messages that remind them to set goals, and they continue to engage in that way. So part of the reason that we wanted to add the audio aspect is in past studies we've done with text messaging, people have said that they wanted more of an aspect of being able to like hear another person talking and not just texting back and forth, which can feel a little bit impersonal. So that's why we added that aspect. We did a pilot trial with 5 people and now are continuing to enroll and randomize 30 more people. We are using eligible participants that are between the ages of 45 and 64. They do a baseline assessment where they wear an accelerometer belt where we get a baseline of their physical activity, making sure that it's below 150 minutes of moderate to vigorous physical activity a week. And if they do, they're either, after doing some questionnaires, randomized to a waitlist control group or to start the program right away. The primary study outcomes for this trial are feasibility and acceptability for the text messages and audio sessions. If it's something that proves to be feasible and acceptable and people like it, then we want to look at doing a trial with more people, integrating aspects from exit interviews we're doing with participants to get their feedback, and possibly try to do this in other languages as well. Thank you.
Thank you. Any questions from the audience?
Jen, what was the utility rating scale if there was a specific assessment used for that?
For, did you say for feasibility?
For utility. I believe it
Oh,
was.
for utility, yeah, sorry. We made our own scale on a scale from 0 to 10, 10 being highly rated, 0 being not, and we're using that.
Awesome. That's cool that you developed your own scale. My team usually uses the CSQ or the UMAR scale.
Oh, yeah. Thank you.
Any other questions for Nikita? Okay, good luck with your study. Okay, next we have Danielle.
Awesome. Can you see my screen?
Yes, we can.
Okay, perfect. Okay. Good afternoon, everyone. So my name is Danielle Downey. I'm excited to share findings from the study IDBT therapy for substance use disorder, looking at how DBT skills and treatment engagement relate to treatment outcomes. So as we know, substance use disorder is a pervasive global health concern, and unfortunately, access to effective, scalable treatment options remain quite limited. So this study was born out of the need to deliver evidence-based interventions in a way that's both accessible and engaging. So we evaluated this program called Pocket Skills. So Pocket Skills is a 12-week program. It is self-guided, internet-based DBT intervention, or IDBT. The program teaches foundational DBT skills, things like mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness. So our study had two primary aims. The first was to examine if participants showed changes in things, important outcomes like SUD severity, functional disability, the HUDAS if you're familiar, and DBT skill use over the course of the 12-week program. And then the second aim was to explore whether treatment engagement, which we measured using duration of app use, so time spent in the app, moderated these outcomes. So we recruited 72 adults, and they completed measures at both baseline and at 12 weeks. So what we found, first, that there was significant improvements in both SUD severity, aka a decrease in SUD severity, and disability over the 12-week period. We did not find statistically significant changes in self-reported DBT skills over time. Interestingly, though, longer use of the IDBT program was associated with lower SUD severity, suggesting that engagement does play a key role in treatment effectiveness. And additionally, emotion regulation and mindfulness did stand out as key predictors of improvement. So in terms of implications, our findings support the idea that self-guided digital IDBT programs may be a viable options for individuals with SUDS, especially those facing treatment access barriers. And given the diverse demographic and clinical profile of our participants, these results suggest strong potential for scalability and broad applicability. That said, of course, there's a couple important limitations. So our sample size of 72 is relatively modest, and the follow-up period of 12 weeks is relatively short. So we also need to address the lack of measurable DBT skill change. It highlights the need to investigate how users are really engaging with the skills, when, how, and whether they're applying them in daily life. So in the future, we hope to include longer-term follow-ups, strategies to ideally enhance engagement, and then deeper exploration of the mechanisms of change, especially emotion regulation and mindfulness, given they were indicated as predictors in this study. So thank you for your time, and also thank you to the CAMH Foundation for supporting this research. Happy to take questions.
Thank you, Danielle. Any questions? I think we're feeling a little shy towards the end of the poster session. Okay, then please put some questions for Danielle in the chat. And then we have, last but not least, Adam. I'm not sure what time it is where you're at, but please take it away.
Awesome, thanks, Sue. Just checking that you guys can see the screen there.
Yes, we can.
Cool. It's about 6:20 in the morning here in New Zealand. Hi everyone, my name's Adam Hutchinson. I'm the founder and CEO of a startup here in New Zealand. We're called Overcome, and what we do is make exposure therapy a lot more accessible for people. And what I'm going to present to you here is a clinical trial that was conducted by the University of Otago, testing whether someone that had social anxiety could actually overcome it using virtual reality, and specifically on their smartphone. What we know is that social anxiety is a really big challenge for a lot of people all around the world. This translates to not being able to go out in public in many cases, not being able to go and attend events, not being comfortable in workplace settings. So has real world consequences for people that have it. And what we know is that 90% of people can't access exposure therapy because it's just really, really difficult to go and physically access those environments. So by using virtual reality and specifically targeting the smartphone, it means that we can develop an intervention and deliver it to people in their homes. So actually bringing those environments that they need to access into their homes in a really cost-effective and scalable way. And just to let you know which perspective I'm presenting from here, this is very much from the technology perspective. The trial was done through the University of Otago, so I might not be able to answer some of the design sort of methodology questions that came with the trial. However, what I can talk about is the intervention and how it works. So the way it works is someone that went through the clinical trial would download the Overcome smartphone app. They would receive like a Google's Cardboard style headset in the post. They would go through generally a 4-week program, which was a CBT-based psychoeducation, teaching them the skills about managing anxiety. They would then go through an exposure therapy program, like multiple exposure hierarchies that were really tailored towards their specific triggers. We would learn about what their triggers were. So was it, for example, having a face-to-face conversation with someone? Was it attending a large sort of crowd, say a music festival? And once we learned what those triggers were, we were able to put them into a specific VR exposure hierarchy. In a gradual way, we would collect SUDs throughout that as well, and we're able to personalize that as well. So, for example, if I really struggle in large sort of audiences, I'm able to experience lots of different types of things. It might be a wedding, for example. It might then move on to a large music festival. So what we found in the clinical trial that over a longer period, which was 18 weeks, we were able to get on average a 50% reduction in severity of social anxiety. So there were 126 people that went through the randomized controlled trial, and the results were as such. So basically, the test was, could we deliver a very low cost scalable intervention to people using really low cost technology, therefore not using a MediQuest? Could we deliver it by the smartphone? And were people able to go through it sort of self-guided? And the results were, as I mentioned there, a 50% reduction at 18 weeks, which was a really good result for the program. This was all based in New Zealand. All of the content was filmed in New Zealand. However, we have now started filming in the US as well. So yeah, that's our goal: make exposure therapy a lot more accessible, make it a lot more affordable for people, and at scale. And so yeah, doing clinical trials, this is our second clinical trial, is a way that we can really test the efficacy of the product and really give people the confidence when they go through the program that the effort and the energy that they put into it, they know that it's worth doing, because there is some evidence behind it to say that if they put the time in, they'll get the results. So yeah, hopefully that sort of talks a little bit about the product, a little bit about the trial, and happy to answer any questions that you might have.
Yes, come on. Thank you, Adam.
Yeah, great presentation. I was just curious, did you find that there was a very large need for patients that are in therapy who are like unable to participate in these real life social anxiety exposures, like ordering a pizza on the phone or going to your grocery store or talking to a cashier? Is this like meant for people living in more rural areas? Or I think just like I understand a lot of phobia treatments, like if you're really spiders, it's really difficult to like find a spider and expose yourself. So virtual reality is very immersive, but for something that's so accessible as like going outside and trying to talk to someone in a store, what's like the best use case in your opinion for this virtual reality?
Yeah, I think there's multiple use cases just because the problem is so large. You know, a lot of the people that went through the trial weren't even comfortable leaving the house, which sort of talks to the severity of the issue. What it means is that that being one particular issue, that even though it's relatively easy to go and access a large crowd, for that individual, they're really not going to do it. So by using virtual reality, I think what we're doing is creating a bit of a middle step. And what we're able to show is that those people that weren't comfortable leaving the house after doing the program were able to, which was really, really a great result. So that's number one. And then to the rural point, which I think is a really important one, these environments, these physical environments that you know, you really need to go and access. For many people in the rural setting, like that is really, really difficult to go and access as well. So I think location is a really significant one. But then we're also seeing that stigma is a particular challenge as well, particularly for men. That even going sort of addressing that sort of first point of care is a challenge. So the anonymity of this as well was also a real factor for people as well. So yeah, I think those are a couple of sort of points, I guess, that talk to why people can't or don't go and access you know, those physical environments needed for exposure therapy to be effective.
Yeah, that kind of gets to my second question. So this like VR system can be used as like one of the steps in a larger like systematic desensitization,
100%.
desensitization therapy plan. It can be like a tool that clinicians use.
Yeah, and ultimately our goal is to do ourselves out of business, right? Like we want people transitioning into the real world, and that's part of the way that we are designing a new sort of slight version of the program to improve it even more, is to basically get people sort of going out and taking that step out into sort of gradual real world challenges as well. It is that middle step, and the plan is to graduate people to the next step, which is in vivo exposure, and then ultimately to the end goal, which is just them to overcome their goal completely. So we're just one step in the journey, I guess, but an important one, and one that's not there at the moment. So that's our goal. That's the place that we're sort of comfortable.
Thank you.
Thank you. Okay, Danielle, and then I'm also happy to open it to, the audience member to ask. Whoa, where'd my video go? There we go. I'm not sure what happened. We'll take Danielle's question, and then if you guys also have questions for Adam or the other presenters, please feel free to raise your hand or put them in the chat.
Cool, thank you. Adam, I have a couple questions. This is really interesting. How was social anxiety measured in this?
The Leibowitz social anxiety scale was the main one. So we captured baseline, and then we captured sort of global impression of change, as well as at the week 6, week 12, and week 18.
Okay. So that was a self-report measure?
Yes, it was. Yeah.
And then, so I heard you say about creating the hierarchy, but then I also see in the discussion that it's without therapist guidance. So who is creating the exposure hierarchy for the participant?
So we're sort of, as part of the psychoeducation, they're going through, and for the most part, they're learning for the first time about what triggers are. So that sort of forms part of the psychoeducation. And then once they've sort of gone through that, they're able to sort of self-report their triggers. And then from that, we're able to do a little amount of personalization with regards to that hierarchy.
Okay, so like the app team is helping develop the hierarchy?
You could say that for someone that doesn't go through and, for example, give their indication of their specific triggers, there is a sort of a default hierarchy that they would go through. Where someone does go through and report and self-report their triggers, then the personalization sort of comes from a personalization algorithm that's been developed from clinicians and going through sort of the library of content where we've gone through and identified what the triggers are that are contained within each environment, and then we're able to apply a small amount of personalization for that individual. If they know that's what their trigger is, then we're able to sort of adapt what the what the hierarchy should be for them through the personalization algorithm.
That's really interesting. I have worked with people with symptoms of obsessive compulsive disorder and lots of exposure work in that too. And I think this could also be very valuable for that population too.
Well, I mean, we've got a clinician portal, which is basically a way for clinicians to be able to access our entire library of content, which is about 1,000 different environments across about 18 different conditions. And we generally sponsor it to research organisations as well. We've got a couple of universities that are using it. So if anyone is interested in that, by all means, just reach out to me and I can organise that. So yeah, like we're always looking to apply the platform and see where virtual reality can be used across a lot of different types of conditions. So absolutely keen to support any research that is taking place out there.
Cool, thank you.
Well, thank you everyone so much for this, for the presenters, for your incredible research and work that you're doing, as well as for the audience members for all your wonderful questions. If the presenters, you don't mind adding your email addresses in the chat, I think that can also facilitate any conversations post conference. And I'm going to make sure to end right at 50 so that everyone can go stretch, be a little bit on 3D world a little bit, get some water, do some stuff, and then join us again at 3 o'clock Eastern time for our next set of sessions for the conference. Thank you so much, everyone.